Good afternoon, everyone, and thank you so very much for inviting both myself and obviously Tim will say his own hello, but for inviting us both to talk about the national programme and what we're trying to achieve. But I would just like to start by saying that, of course, we're acutely aware that a national programme may, and I hope it does, provide a useful framework to guide or inform many of your discussions. But nothing really changes unless it changes locally, unless it's changing at the level of people with lived experience, their families, and the partnerships that come together around them. One of the things we've been told in the lunch break about this audience here today is how many partners there are here. I want to particularly welcome people like the police, the acute sector, the third sector, patient groups, because it can feel, I think, when you're passionate about mental health, as though sometimes mental health talks to mental health a lot. And we get really excited, and generally as we get excited, we also then get pretty resentful that others don't understand us and aren't interested in mental health. And so I really commend you all for the quality of the partnerships that you have and that you're trying to build and strengthen. I believe absolutely that we can only deliver great mental health services, world-class mental health services, if it's an issue, if it's a programme that belongs to us all. Just two last things though, about why I'm so pleased to be here today. I was born and grew up in Kent, so I have a very, very, very soft spot for this tremendous county. And although I've lived in London for many a year, it always feels like I'm coming home. And it drives my husband mad. We live in London. That I say, oh, I think I'll go home for the weekend. And he goes, hello, your sons, me. So it feels very nice to be here today. And the other thing I just wanted to say, and I don't want to embarrass Helen, but Helen Greatorex and I trained together as nurses at Friern Hospital. There were about 8 people in our group as nurses, and you got to know each other really well throughout those challenging and exciting years. And it would be fair to say that Helen was constantly impatient for change. She wanted to change the world and had an absolute passion for better mental health services. So, of course, it's even more thrilling to be here today, Helen, and to see you and partners and other stakeholders wanting to change the world, or this part of it at least. Very briefly, I'm hoping that this, nearly my favourite slide in terms of the national programme, will be familiar to you. It's my favourite slide because it makes simple an immensely complex national agenda around mental health. It sets out not all, but most of the main work streams and most of the main commitments that we together have made to the public around things that we will improve by 2021. Just to remind people, the Mental Health Task Force, independent task force, reported back in February 2016 and made 58 recommendations after spending a year talking to more than 20,000 people, professionals, people with lived experience, partners and others, public, about what needed to change and improve in this country's mental health services and what was good about them. That task force made 58 recommendations for change, which were published in February 2016. About half of those recommendations were for the NHS. They were about services that the NHS simply needed to make more accessible, to develop where they didn't exist, and to expand. So the mental health agenda is a growth agenda. The services, the main programmes of activity that Tim and I and the whole team nationally are charged with delivering are primarily the NHS half of the 58 recommendations. I think it's critically important that we acknowledge that the other half of those recommendations that are to do with employers, schools, local authorities, citizens themselves, and other bodies, that action is needed in that area or those areas as well. And we, the NHS, if you like, don't overvalue what our contribution is in much wider cross-societal advances around better mental health care, better resilience, better integration with physical health care, thinking in a more whole person way, taking issues such as debt, employment, good schooling, pastoral care, all of those things need to be taken seriously. So a limitation of my presentation today is it will focus on the NHS commitments. And another limitation is this is a step to 2021. It's a step on a journey. It's a step on a journey that needs to last for the next 10, 15 and 20 years. There are gaps in the 5-year forward view for mental health. There are some things that are not prioritised that we know are tremendously important to people. We say very little about autism, the overlap between mental health and learning disability, adult eating disorders, personality disorder. There are things we say little about, and I know in particular, and you'll say more about it so I won't now, but I know Professor Kendall is already working with clinicians and others across the country thinking, what will the next 5-year forward view for mental health look like? Because we need to start planning it now. Anyway, I'm not going to take you through the detail of each of these, but just to remind you, because the screen is small, we have said that by 2021 we'll see 70,000 additional children and young people in our CAMS services. That will take us up to seeing 1 in 3 who need a specialist CAMS service. We're currently 1 in 4. And we were reflecting over lunch, that is a bit like saying we'll see 1 in 3 children with diabetes in the NHS by 2021. I wouldn't even say cancer, because, you know, that's shocking. Just think diabetes. Would we think it's okay? Helen, you said, is this ambition ambitious enough? Almost certainly not. But it's worth delivering. So, you know, and if we achieve this step by 2021, we will have done a tremendous amount. We have set up something like 72 children and young people's eating disorder services in the last year, so that's progress. We have to expand access. My plea to you is please digitally record all your contacts and make sure that this comes through to the national body. We want to be almost able to count every one of those 70 children and know their middle names and their football teams. Because if we can't demonstrate we're doing it, people don't tend to believe we're making any progress in mental health. So please record and work with us on that. Tim will say more about the green paper, so I'm not going to mention it now other than to note that will be in addition to this programme. We've said that every area of the country will have intensive home treatment teams and crisis teams by 2021. They're pivotal if we are to realise our ambition to avoid more hospital admissions and to shorten the length of stay or time spent in hospital and deliver care closer to the point of crisis and indeed before crisis. And we certainly know that in all of these agenda, the relationship with the third sector, the other sectors and health is critical. So we know in some parts of the country they're doing things like their home treatment teams will also have access to a crisis cafe or other things out of hours that maybe the NHS is not providing, but that can really help think in a 24-hour way about need. We've said that all acute hospitals will have a psych liaison service in place by 2021. And Helen, as you said at lunchtime, half of them. I wondered, could you say half with any more dripping disdain than you said it? I'm not sure you could have. But you're right, we've said that half of them will be Core 24 by 2021. That's the full standard. And we know, and Tim may say more about this, that there's a huge evidence base that if you do it properly, you know, don't prescribe half a course of antibiotics and be disappointed when it doesn't work. You know, you need Core 24 services to have the impact on health, on outcomes, on engagement with patients, and on the pressures in the acute system. I think sometimes we talk about the pressures in the acute system as the main reason we'll justify doing anything we do in mental health. No, we do it first for patients, but how brilliant it is if we assist our acute colleagues and help deliver better care on the wards there and in A&E. We did fund 72 of those services nationally last year and this year to help prime them. They are then subject to local pickup by CCGs in terms of funding. So we have kept some of our funding to seed new services and new developments, but this is very much about localised responsibility and ownership by the end of the period. 30,000 more perinatal women will receive specialist care by the end of the period. When we embarked upon this journey, some benchmarking was done, and we found that something like 14% of women nationally had access to specialist services, the rest not. So we last week were looking at wave 2 applications to roll out specialist perinatal services. They are another good example of where what we're funding is primarily specialist NHS care for women in that pre- and postpartum period who are really vulnerable to major mental. I'm thinking of reclaiming the word mental illness, actually, because I think we use mental health and mental illness interchangeably, and I'm not sure it helps us, but I'd really value feedback on that when perhaps we get to the Q&A. But it helps women with really quite severe illnesses or being in danger of developing one. However, the most successful teams we know are absolutely delivered with the paediatricians, health visitors, midwives, the GPs, third sector groups, women with lived experience, and so on and so forth. We want to reduce suicide by 10% by the end of the period, and Tim is leading our work on that, so I won't say more because you may touch upon that. But again, a great example of you really only do achieve a proper reduction in suicide rates if you have really excellent multi-agency system working. I was talking to an MP this morning who asked me what I thought of the British Transport Police, not randomly, but in this context. And we know that they've done some superb work with local partners across the country around the risk of high-speed rail stations, for example. And every area will need to know its risks and opportunities and routes into reducing suicide. We've said we'll increase access to psychological therapies. And in particular, and I think you're going to talk a bit more about this, we're having a big push on psychological therapies. This year we've run some pilots for people with long-term conditions, and we're starting to see some stellar results around how you change life for people with long-term conditions. Another great example of integrating physical and mental health care. We think our Talking Therapies programme is, I feel like a Heineken advert, isn't it? Was it Heineken that said Reach is probably the best beer in the world, or probably Reach is the beers that other beers, parts that other beers can't rate, probably the best lager in the world, that was it. We think we've probably got the biggest coordinated talking therapies programme of anywhere in the world. And that's what our objectives here will deliver. We'll see 600,000 more people by the 2021 period. We are seeing about 100,000 people a month come into talking therapies currently. And one thing that's been going on social media at the minute is a bit of pushback I've noticed in the last few weeks about common mental health problems, and people feeling that diminishes sometimes the incredibly debilitating and the suffering that can go on if you have a common mental health problem. So I think we absolutely should value this programme as well. We've said that we will double, at least, the numbers of people accessing evidence-based employment if they have a mental illness, serious mental illness. Winston Churchill, who, if you do lots of public talking like I do, he's a great source of quotes, not least of all because he's invariably very rude and witty. But one of his quotes when I was searching, he said something I really like. He said, "You make a living by what you get and a life by what you give." And of course, for most of us in this room, work is a big way of giving and engaging with the rest of society. It's more than just putting food on our tables and paying our rent, though that is important. So we're very passionate about this scheme, and calls are out at the moment for bids to, we've got 2 waves of funding to support the employment programme. We are in wave 1 building on existing programmes that are exemplars, and we want to expand them. And wave 2 will be for areas that are more fledgling to help you strengthen and develop. And we're hoping the wave 1s will help the wave 2s is the idea. What can I say about physical? And perhaps, Tim, you're going to say a little bit about, I don't know, but physio or not. But, you know, clearly one of our big scandals of our time that we're a bit complacent about, I think. So we go, oh, yes, it's shocking. But really the fact that people are dying prematurely 15 to 20 years earlier if they have a serious mental illness, from physical health problems. And I think, well, people have been somewhere before they die 20 years early with their hips and hearts and lungs. They've been in the hands of mental health services, general practice, in the acute hospitals. They've been through so many of our hands, but what have we done to change the course of that? And it links, so we've said that 280,000 people will have evidence-based health checks annually, with not just a check, but obviously a plan then to back up healthier lifestyle and longer life. Which feeds very much into first episode psychosis. So we've pledged to, by 2021, and we're back to your ambition point here, Helen, that 60% of people will have, from referral to treatment, will be seen and begun treatment within 2 weeks. Actually, nationally, we're above 70%. You and colleagues across the country are really prioritising people with that first episode. But we're not doing so well on nice concordant care within 2 weeks. We have until 2021, and I think you are going to say something about that, so I won't say more. Inappropriate out-of-area placements I know you're going to talk about, and I know you've done great work here, but it's we're really passionate about seeing an end to that and spending both the money and seeing the improvements in quality of care. New care models. We currently have about 1.8 billion pounds worth of mental health money with specialist commissioners nationally. And they buy, in particular, services for inpatient forensic care and Tier 4 specialist child and adolescent services. They also do buy some other very specialist services, like services for deaf people with mental illness nationally. But the vast bulk of that 1.8 billion is in the forensic and Tier 4 space. We've introduced new care models across the country, which are provider-led, NHS provider-led, but the areas where we've been happiest to devolve responsibility for those populations and the money are where the partnerships are really strong with third sector, housing, local authority and others, to really make sure that we can redesign care. So it links a bit with the same sorts of capabilities as our out-of-area placement thinking and maybe lot rehab, which I'll talk about later. We've had 2 waves of new care model funding, and I met with Simon Stevens recently for a one-to-one and asked him, are we doing a wave 3 or are we just doing this? i.e., are we just going to move to a more devolved, local, population-based leadership and responsibility around these populations? And he said, why do a wave 2? Let's see how quickly and sensibly we can devolve care in these areas. I'm very excited about that because I feel it starts to bring together again that which the 2012 reforms kind of rent asunder, but I don't know if I'm allowed to say that. I've just said it anyway. And then finally, we are trying to open CAMHS Tier 4 beds in the right place. So although, and Tim, you do this more perhaps than anyone, you champion the fact that beds are not always the best place. In fact, quite often, and particularly for children and young people, they're the worst place. But we have a dearth nationally of crisis alternatives, of 24/7 capacity. And whilst we build that through some of the plans I've mentioned earlier, we have to open units to stop this business of shipping children and young people across the country for emergency admissions to specialist units. We're opening 150 beds this year by the end of March. We've opened nearly 100 already. London and the South have been particularly underserved. So I think we felt this lack of Tier 4 access more in our areas perhaps than elsewhere. I do just want to say, Helen, is it your trust that's opening the mother and baby unit soon? I'm so excited. Just going back to perinatal, we are opening 4 MBUs across the country in underserved parts of the country. And we're also expanding 15 MBUs that already exist but don't have enough capacity. So again, that localising care, knitting it into the perinatal services that exist. I mean, it's going to be gorgeous. I think you're opening yours in the summer, aren't you? I was saying we should ask Kate Middleton, but I think she's having a baby herself then, is she? Had you thought of that? It would have been great. I'm sure she would have loved to have done. So the next few slides, I'm not going to take you through. They literally... This is me talking about some of the progress that we're making, the fact that we're trying to support integrated systems at a national level. We know that all of you are, we're not allowed to call them accountable care systems anymore. I don't really mind what we call them, but I think these partnership systems around the needs of populations more locally configured are in line with what you're doing here. And here are just some examples of what the national team are trying to do, the materials and the sorts of supports to support your partnerships. They're small. I'm hoping these, I was told these will all be in your pack, so I'm not going to talk through every slide because I want to stop. Tim will say perhaps a bit more about physical and mental health integration. We've got to stop doing this to people. LTC and IAPT, site liaison and so on and so forth, great opportunity. I've talked a bit about the case for change, but we do think that we can save something like £1.4 billion by more integrated services. This just shows you where we funded the core 24 services, just so it's real and you know that we really are doing this, so you can look at them at your leisure. I've talked about IAPT, and I think you're going to talk about long-term conditions and IAPT a bit more now, not so much. Look at Cambridge and Peterborough. They're doing some great stuff around long-term condition, long-term IAPT in long-term conditions. But again, this just shows you who our Wave 1 and Wave 2 early implementers are. You can see it on the maps here. We want to whet your appetite, because if you need anything from the national team, if you want to know about anything about any more of these slides, please just contact us and we'll have a little small army of people who will come and share knowledge and information on return on investment or where's working really well with you. I'm not going to talk about eliminating out-of-area placements because that will be Tim. That's your absolute thing. This shows you where the new care models are. We're seeing some extraordinary new care model results. My own trust was a new care model Wave 1 for Tier 4. And we have drastically reduced the need for inpatient beds. We're investing in crisis and out-of-hospital alternatives. Our community eating disorder service, which you visited recently, for children and young people, is impacting massively on the need for CYP eating disorder beds. And each one of these areas across the country has got a great story to share. So please do visit or find out information. And I want to. Digital, this is not my great area of expertise. I was going to be incredibly ageist and say I'm too old, but really important that we improve the use of data and system interoperability. I know you know that. Really important that we promote more digital use and self-help through materials that are there online for the general population in building resilience in mental health. And really important that we develop more therapies that are digitally assisted. And Tim, I know you're leading the work on the digitally assisted therapies. Really important. We have got, and Tim's next, just finally, I do remember when 10 global digital exemplars were announced about 2 years ago, and they were all in acute hospitals. And social media went wild with continuity of neglect type stories because no mental health providers were in those first digital exemplars. But actually we do now have several global digital exemplars of our own nationally, all of whom have had at least £5 million additional funding each. And the idea is that they really trailblaze for us how far we can push digital therapies to reach more of the population. So it's an exciting agenda. That was a real whistle-stop tour. We are making progress against nearly every domain, and we are making progress because people such as yourselves, a widespread of agencies and colleagues, are doing such great work. So before handing over to Tim, I have the very great pleasure of thanking you all, and thank you for listening to me.